I get the pleasure of introducing everyone, which is fantastic. So I'm going to read this to you, so I don't mess it up. But this is Dr. Franchesca Konig. She's a board-certified physical medicine and rehab doctor, trained in cancer rehab medicine, so something very specific. She's originally from Puerto Rico, and she trained in Puerto Rico, and I have been to Puerto Rico, and the Bio Bay is awesome. The Bio Bay is awesome. I hope it still exists. I hope they haven't poisoned it. She completed her residency actually in Rochester, and she did her specialty cancer rehabilitation training at Memorial Sloan Kettering in New York City, where a bunch of my friends are. She then became an attending, and she's now here in the Anschutz campus. And so we are very, very blessed to have Dr. Konig talk and to share her experience and her knowledge about how cancer rehab is different and what it means to you. And remember, this is just not about you having cancer. It's about how you can live better. So, ladies and gentlemen, please, let's give her a round of applause, Dr. Konig.
Thank you. Thank you so much. I'm so excited to be here today, folks. Thank you for having me.
Don't step on my tennis racket.
Okay, got it. We might swing a little bit to get some arm range of motion, but thanks everybody, and thanks for the introduction and having me. So like Dr. Lou was saying, I'm a cancer rehabilitation medicine physician, and I love talking about cancer rehab medicine. I'm very passionate about what I do. I think everybody who has cancer should be seen by a cancer rehab doctor, because wonderful folks like Dr. Lou and our oncology teams, they save lives. But what do? We help save lifestyles. And so this is where, again, cancer rehab has a great impact in folks with cancer. All right, so no financial disclosures. I always put a disclaimer here that I talk fast, so maybe one of you can give me a little tug if I'm going too fast here, but there's a delay. I was told to press once. I'm gonna press, there we go, okay. So just a quick introduction. I did my training in Puerto Rico, which is where I'm from. Residency was in Rochester, New York, and then trained at Sloan Kettering, where there are 8 of me, or I think now 9 of me. And then here, to my knowledge, I'm the only one who's fellowship trained in the state of Colorado and at Anschutz. And so I'm very excited to be here. I joined about 3 years ago and trying to continue expanding the practice so that I can help folks also outside of Anschutz. I'm a one-woman show right now, and so trying to do the best I can, but we're gonna get there. Oh geez, sorry guys. I'm a geriatric millennial. No, exactly. Phew, we're good. Accurate. So just going to review the history and definition of cancer rehab medicine, understand how cancer rehab medicine integrates into this oncologic model of care, and then review some of the conditions that I manage as a cancer rehab specialist. So what is cancer rehab medicine? First off, I like to talk about physical medicine and rehab because there has been a lot of confusion as to what we do. It's our fault. We have not been good at marketing ourselves, and the next slide is going to show that a little bit. But we are physical medicine and rehab doctors, also known as physiatrists, also known as rehab doctors. And so that can get very confusing. I would say about 90% of my patients, when they come see me, they also see me in the spine center, and they see me in a GI surgical oncology clinic, so they have no idea why they're there. And so I always have to explain what I do. And so some folks think that we are psychiatrists, some folks think that we are podiatrists, some folks think that we're physical therapists. And you know what, to be honest, we're a little bit of everything of all of that. So, but physical medicine and rehab essentially are function and quality of life doctors. And so this is what I do, but specifically in the cancer population. And so the definition of cancer rehab, we as a group have been trying to come up with a good definition for many, many years. There's been many iterations of this. And my colleague, Dr. Silver, out in Boston, came up with this definition that we have all agreed upon. And so cancer rehab is medical care that should be integrated throughout the oncology care continuum, delivered by trained rehab professionals who have it within their scope of practice to diagnose and treat patients' physical, psychological, and cognitive impairments in an effort to maintain or restore function, reduce symptom burden, maximize independence, and improve quality of life in this medically complex population. And I highlight the 2 parts that I love the most about this definition is that we should be there from the moment of diagnosis throughout, and these are our goals. We want to make sure that you are able to do the things that you need to do. But what I tell my patients too, it's not only what we need to do in our day-to-day, but it's what we want to do, right? Folks want to, again, like Dr. Lou was saying, see their grandkids graduate from high school. They want to go on a bike ride. They want to be able to go back to work. All of these things matter. And so we're here to help folks reintegrate into their normal lives, or a new normal, which isn't always necessarily a bad thing, right? But we want to do that effectively for our patients. And so this is just a timeline of physical medicine and specifically cancer rehab medicine. So this is where I start saying that, again, marketing, we are the problem. We've been around since the 1920s, initially with the American College of Radiology and Physiotherapy. That's one of our national groups. In 1938, the American Society of Physical Therapy Physicians, this is where marketing becomes an issue for us. We called ourselves physical therapy physicians. This is, again, now AAPMNR, which is one of our biggest national groups. PMNR really got into the scope of things in 1941 with World War II, our soldiers coming back, trying to, again, reintegrate into their lives. How do they do that after having served? And then cancer rehab really became more on the forefront of things in the 1960s and 70s. There were a lot of acts and laws in the legislature that was really promoting knowledge and support for chronic illnesses, strokes, cancer, cardiac illnesses. These were the decades that MD Anderson in Texas and Sloan Kettering in New York first employed their first rehab doctors. And since then, we've grown exponentially. So present day, and I always forget to update this slide, but I think we have 11 fellowship programs throughout the nation, and also one in Canada right now. And so to put this into perspective, I finished my fellowship training in 2019, and at that point there were 5 cancer rehab fellowship programs where we do a 1-year training specifically for this. Fast forward now, right, we have 11 or 12 of those, so it's growing. And we're a little bit of everywhere. So next. I hit it once already, I promise, guys. I'm gonna do it again. There we go. So just a map of the US, right, where we're at. We do a really good job on the East Coast, and I was part of the problem over there. We have a lot of folks doing a lot of good things, but as you see, as we come across to the Midwest, to the western parts of the nation, there's not as many of us. And so what really happens here is that, right, we have all of these fellowship programs. The fellows, the doctors that graduate from this go off, they graduate, they start new programs. And so this is what's happening. And you know, our goal is to take over the world, and we're working on it. So, you know, one state at a time. Like I said, to my knowledge, I'm the only one that's cancer rehab trained here in Colorado. My closest colleague is at KU in Kansas, and we have some folks in Arizona and then California as well. But we recognize that we have a lot of work to do, and our goal really is just to serve our patients and make sure that everybody with a diagnosis of cancer has access to these services. And I talk a lot about, again, cancer rehab, and again, I'm a physician, but this is a whole group effort here. This isn't just physicians. This is physical therapists, occupational therapists, speech therapists, nutritionists, everybody, right, that thinks about lifestyle for our patients. That encompasses cancer rehab. And so this is where we're talking a little bit about how we integrate into the oncology care continuum and why that's important. So Dr. Dietz was one of the first rehab doctors employed at Sloan Kettering in New York City, and he came up with this classification of the role of cancer rehab throughout the oncology care continuum. And there's 4 stages. Number 1 is prehab. Number 2 is restorative rehabilitation. Number 3 is supportive rehabilitation. And number 4 is palliative rehabilitation. And we're going to go into each one a little bit. So prehabilitation, or what we just say is prehab, is at the moment of diagnosis before the onset of treatment, whether that's chemotherapy, radiation therapy, targeted surgery, all of that. And so when I see a patient after their diagnosis, prior to treatment, my goal here is to get a good understanding of what life looks like. What life looked like before your cancer diagnosis. What were you doing? Were you somebody that was out hiking for teeners? Were you somebody that had really bad knee arthritis? What impairments, what other things was going on in your life? Because those things are still going to be present while you're undergoing your treatment. And we don't want any of this to limit success with treatment. So we have to identify all of these impairments so that we can target it. So we do a good functional evaluation, identify impairments, and provide any interventions, again, to promote physical and psychological health to reduce some of that symptom burden as we're undergoing treatment. The next step is restorative rehabilitation, and I kind of see this as getting over the hump of treatment, or active kind of acute treatment. So this might be after surgery or during active treatment, and here we want to kind of return to previous levels of functioning in the realms of physical, psychological, social, and vocational. Again, depending on what patients want to do. Some patients want to be working throughout treatment. Some patients want to, focus on themselves. So there's all these goals, and this is where individualized work and one-on-one is so important, and coming up with a plan of care together, right? This isn't something that I'm just going to dictate what you know. This is something, a discussion, a conversation, and doing things together based on your goals. Next up, we have, I hit it again. There we go. Supportive rehabilitation. This is when we think maybe cancer treatment results in permanent or likely permanent impairments. And here we want to reestablish functional independence. Now that we know potentially, some folks have neuropathy from chemotherapy, and unfortunately sometimes that's a permanent impairment. But what are we going to do to make sure that we're able to get back to what we want to do, back to what we need to do with that impairment in place? So here we're focusing on self-care ability, and again, reintegrating into life. And then palliative rehabilitation is the last stage. And this is unfortunately where we may have progression of disease, or we're thinking more of end of life. And I think that physical medicine and rehab and cancer rehab medicine is not necessarily thought of during this stage, because folks might assume, oh, we want to do just comfort care. Patients just want to be at home and not doing it, just, relaxing. But that might not always be the case. I always recall one patient that I had with a brain tumor who was out skiing his whole entire life, if quadruple blacks existed, he was there. And as his disease progressed, he was unable to do that. But he wasn't somebody that was just going to be at home lying in bed. He wanted to exercise. He wanted to do things. But what did that look like? Safely, right, with his neurologic deficits. So here we really want to maximize patient comfort, but also support and goals and improve that quality of life. So as you can see, there's a role for us in all stages, and my goal is to be there again from the beginning and throughout. And so the role of a cancer rehab medicine doctor, so anytime I get a referral for a patient, it might be for, let's say shoulder pain. I'm going to address that shoulder pain, but I'm also, again, going to be doing a very comprehensive evaluation, again, asking, what did life look like before cancer? How are you moving now? What other things are potentially limiting you in your day-to-day? I like to look at the whole cancer history and ask questions pertinent to that. You had surgery. Do you still have pain after surgery? Are you experiencing fatigue? What are your energy levels based on treatment? Because I have that knowledge of what could happen based on your treatment, and sometimes this is your first rodeo. You don't know what to ask. You don't know what's normal. You don't know, what to expect. And I want to give some of that guidance when I see patients. So performing a really good comprehensive evaluation is one of my goals. I help assist in diagnosing different types of impairments. So for example, again, going back to shoulder pain isn't always from the shoulder. It can come from different areas. And so helping diagnose that efficiently. My favorite thing, apart from seeing my patients, is working in a team. And I'm a little bit of a self-proclaimed over-communicator. So when I see a patient, I route my note to the whole entire team. That includes the oncologist, surg-onc, radiation oncology, all the supportive services, nursing, social work, everybody. Because I think, again, you all are our MVPs, and we need to serve you as a team. That's how we do it best. So I really like working in a multidisciplinary fashion. I can also help different oncology teams determine, is this the right treatment plan for this patient right now? For example, are they really fatigued, or are they really deconditioned? Are they going to be able to recover well after surgery, or do we have to do an exercise program, get them to a better functional state before surgery. So those types of things I can help with as well. I love working with my therapists, PT, OT, lymphedema therapy, pelvic floor, speech therapy. I really like to collaborate with them. And folks who may not need skilled therapy, I can provide individualized exercise prescriptions as well. I do some non-opioid pain management, orthotic and prosthetic prescriptions, and then I do certain types of interventional procedures like steroid injections and things like that. Again, trying to look at everything as a whole for our patients. I kind of think, and what I describe myself as is essentially a functional and quality of life quarterback for you, right? That's the goal with cancer rehab. This lag. Okay, so this is just a little diagram, again, of a little bit of everything that we do, right? So it's again, understanding everything as a whole. We need to think about your day-to-day. We need to think about, for example, do you have difficulty at home navigating stairs? Do you have difficulty getting in and out of the shower? Do you need a shower chair? Do you need grab bars? So it's just thinking about everything as a whole is helpful, and this is what we do as rehab doctors. And then what we see in the cancer world, a very wide range of impairments, whether it's general or cancer-related or more treatment-related. And oftentimes there's a big overlap, and we oftentimes can't say, oh, your fatigue is just from surgery, or it's just from this one treatment. There's an overlap of all of these things, and sometimes it's hard to kind of tease out what's what, but we have to understand that all of these types of things can happen. Fatigue, pain, cognitive dysfunction, we can get deconditioned. And this is, again, just kind of all cancer types, not just specific to NET, but we have a little bit of everything, and so we're looking at all systems in the body here. And, okay. We're good. I like to bring up cancer-related fatigue, and we're going to talk about this as kind of that big diagnosis, because I always see this as something that's kind of left on the back burner when you come to see the doctor, right? Because maybe folks are expecting that they're going to have decreased energy levels. Maybe they don't feel the need to say something, or your doctor's visits have X amount of time, right? And we have a long list of patients that we have to see and keep on going. And so unfortunately, visits can be limited sometimes. So I feel like, again, this gets put on the back burner, but I always like to bring it up and talk about it. Also because I see this as an invisible disability, right? Folks can feel fatigued, they can have decreased energy levels, and your family members might not see it in your day-to-day, friends might not see it in your day-to-day, but you don't feel normal and you don't feel right. And that's a difficult place to be. So the definition of cancer-related fatigue, or what we call CRF, is a distressing, persistent, subjective sense of physical, emotional, and or cognitive tiredness or exhaustion related to cancer and treatment that's not proportional to recent activity and that significantly interferes with usual functioning. I also very much like this definition because it's not just physical. Yes, I feel physically fatigued, but there's an emotional burden on top of this. I tell all my patients, and I think you all might agree, cancer was not on your life bingo card. Right? And so that takes an emotional toll on us as well. And that fatigue can compound, right? And then some folks can get, cognitive tiredness as well, brain fog. I don't like the term chemo brain because it doesn't just happen with chemo. Sometimes it's with the diagnosis itself. Sometimes it's with other types of treatment. So all of these things combine and can compound and have us feeling tired and with decreased energy levels. And now this is something incredibly common. This is overall incidence in the cancer population, but about 25 to 99% of patients experience fatigue during treatment. 30 to 60% of that can be moderate to severe. And a quarter to 1/3 of longtime survivors can experience fatigue for up to 10 years after their diagnosis and treatment. So this is one of those impairments that can be long lasting and can be very difficult if we're thinking about, okay, we're done with our treatment, now we have to go back to work. But how are we going to go back to work if we still feel tired, if we don't feel like we're at our prime? Or, we want to engage in all of our family events, social events, but that's difficult, right? And so how do we get over that hump? And I always bring up our chronologic versus biologic age, because I have a lot of patients who will tell me, they're 50 years old, they're like, man, I feel like I'm 85, or they're 85, and they're like, man, I feel like I'm 130 right now. Like, they just feel older, right? And there is that difference. we will have that difference between chronologic and biologic. So our chronologic age, I hit the button again, I'm sorry. Our chronologic age is one that advances every year. We have no control over that, right? Year after year, we get 1 year older. Our biologic age, though, is something that sometimes is outside of our control, depending. I'm going to do it one more time. You do? Okay, thanks. Okay, so again, the amount of time that's relapsed or elapsed from birth to your current state. And then the next one, biologic age, thank you, is just, again, the measure of accumulated life course damage to our biologic systems. And the definition here, loss of reserve and vulnerability to functional deterioration and death. So essentially, what we see is that there's different slopes, right, of how we age. And so there's this normative aging, right? We're all going to get there, but then there's things that can advance that and make us feel older, and then there's things that can restore that and make us feel younger again. So accelerated aging can happen with any chronic illness, cancer, heart disease, diabetes, lung diseases. All of this can elevate that slope. And what do we do to kind of bring that down? This is what programs like this is for, right? Exercise is one of those things that can bring it back down and make us feel better. But I always bring this up because I have too many patients tell me that they feel way older than they are, and I think it's something that impacts us. This is another slide that I show the majority of my patients in regards to bouncing back from things. So I'll have patients who get a cold, right? And they're like, man, back in the day, I got a cold and I could bounce back within a day or two. But this time it took me about 3 weeks. And they just feel like it's just that much more difficult to bounce back from hits to the system. And I talk about this as kind of fit, pre-frail, and frail. So a lot of my patients fall under that pre-frail, even if they're quite functional. But it's, again, bouncing back from these hits to the system. Our adaptive capacity and our resiliency to stressors lowers. We can bounce back, but it just takes that much harder to do. And I think it just puts things into perspective. So when we think about cancer-related fatigue, it is very much of a multifactorial cause, right? There's a ton of things that contribute to this. So sometimes, again, with the diagnosis in and of itself, you can have decreased energy levels. I always talk about here when we see that cancer treatment, this stacking or compounding effect of, right? Some folks have surgery, and then they have chemotherapy, and then they have radiation therapy, they have hormone therapy, targeted therapy. All these hits to the system, right, make it harder to bounce back. We can have the complications. Our blood counts can be low. We can be admitted to the hospital. We can have infections. We're not eating enough. We get deconditioned. All of these things hit the system. And then again, we talk about this, the emotional burden of this, the psychosocial burden, right? Not everybody's depressed, but again, I can't imagine somebody's super excited when their doctor tells them that they have cancer, right? It's a difficult diagnosis to wrap your brain around, and that again takes a hit to the system. So all of these things combine to just, again, decrease some of that energy reserves. And so it's awesome because this is a slide that I've prepared ages ago, and it just goes really well with the theme of this program of C's, right? Because I tell all my patients there are 4 things that we can do to feel better. If you have cancer, even if you don't have cancer, right? 4 things. Number 1, exercise, right? That's been shown, proven. We know it. We need to move our body. Number 2 is sleep, right? We need to recharge our body battery. And it's not that if you don't sleep, then, right, you have cancer-related fatigue, but it goes hand in hand. If you have a poor night of sleep, that next day you're not going to wake up all chipper. No, right? All of us are going to be feeling a little bit slower the next day if we didn't sleep well. The next thing is nutrition. We need fuel for our body. I always tell my patients, right, really important, our muscles like protein. We need to optimize that protein, and that sometimes can get difficult if you don't have an appetite or, right, any other hits that decrease our oral intake. And then the last thing, mind-body interventions, right? We have to target how we're feeling. We have to make sure that we are that we're understanding, again, the scope of this, coping with this, the emotional burden of this. And especially for cancer-related fatigue, there's been a lot of studies to look at cognitive behavioral therapy. So there's certain psychological interventions that can help us cope with fatigue and increase our energy levels. And so this was a study from 2017 that I always reference to, and I think is incredibly important because, again, it highlights that exercise should be front of or first line treatment for cancer-related fatigue. Sometimes we will use other things like Ritalin medications to kind of increase our energy levels. And I will use these medications sometimes for my patients, but it's never first line. I always want to make sure that I'm addressing everything else that we can do before we implement another medication. And to be honest, I have a lot of patients who tell me, I don't want another toxin in my body. I'm done. I'm already taking enough, I don't want more. But sometimes we need to use it. So it's important. Exercise should be front of the line. Again, psychological interventions as well. The study showed it. I always reference this. And then when we're thinking about exercise, when we're thinking about exercise, I think it's really easy for us on this side, doctors, to just say, oh, go exercise, eat right. Great, but what does that look like specifically, right? I think depending on how much you exercise or the lack of exercise, just getting into exercise can be difficult, especially after a diagnosis of cancer. And so the American College of Sports Medicine back in 2019 had a roundtable of experts to look at exercise and cancer in general and say what we should be doing. They found that there was strong evidence for the combination of aerobic exercise, which is our cardio, it's walking, it's getting that heart rate up, in combination with resistance training, which is our strength training. And no, you don't have to go to the gym and be a gym bro and lift weights like that. It can be body weights as well. It's meeting you at your level. But that combination is important for the treatment of cancer-related fatigue. And I'll tell you, I have a ton of patients who say, oh yeah, I exercise all the time. I go on daily walks, 45 minutes, but I'm still feeling very fatigued. And this is where I like to explore. It's not just I exercise. It's what do you do specifically? Because if they're doing a lot of that aerobic work, I'm like, let's integrate some strength training for you. And we do that, and they feel better. Right? It's really just understanding what we have to do, and this is so important that they've studied this because it makes a big difference. They also found, again, the combination of aerobic and strength training was important for health-related quality of life and physical function. Aerobic training was found to be really important for anxiety and depression, and then strength training, lymphedema. There's no contraindication, and then there was moderate evidence for strength training for bone health, and then aerobic training or cardio for sleep as well. So again, giving a little bit of guidance, I think, is important as we give these recommendations to patients. And so again, thinking about exercise, it's not just go out and exercise. When I refer patients to an exercise program or to skilled therapy, right, we're getting some one-on-one guidance, and that's awesome. But in folks who don't necessarily need skilled therapy, again, we have to think about this as an exercise prescription. And I will write out an exercise prescription. This is part of your treatment plan. This is just like, the treatments that you take for your cancer. This is part of it as well. And so we think about the FIT principle, and it's frequency, intensity, time, and type. So sometimes folks are feeling very fatigued. They look at those recommendations from the American College of Sports Medicine, and they look at me and they say, I'm never doing that. And I tell them, I get it, but we're going to start low, and we're going to start slow, and then we're going to ramp up, right? And so we think about frequency, and I tell them, maybe we're just going to start once a week. If that's all that you feel you can do, we're going to start once a week, and then we're going to keep on ramping up. So it's close follow-up, making sure that we progress that. But this is where, again, it's incredibly important to understand the impact and the importance of exercise and fine-tune it as we move along. And then the P here is for precautions, because in the cancer world, there can be certain precautions, right? If your blood counts are low, some folks who have spread of cancer to their bone or things like that, we have to have certain precautions. So that's why, again, plug for cancer rehab. You guys should come see us. And then again, thinking about an exercise prescription, important these four aspects of it as well. We really want to make sure that we're doing an individualized exercise prescription. This is not a one-size-fits-all. I think we all can agree on that. We want to make sure that we're progressing things. If you're doing the same exercise all the time and you're looking for improvements, it's going to be difficult, right? We have to make sure that we're moving forward with the type of exercise and the intensity and duration. And then specificity is important, right? Because we have to make sure that it's specifically designed to induce improvements, and then recovery too, right? We can't just do exercise, 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 and you don't give your body a break. So it's a little bit of that balance as well, and this is why these exercise prescriptions specifically are important. And so some final thoughts here. Cancer rehab should be delivered by a trained physiatrist or rehab team, working collaboratively with everybody on your cancer team, and again, integrated throughout the cancer care continuum. And then, sorry guys, here we go. I know I'm in Broncos territory, but in my household we're Chiefs fans, I apologize. I know, but it's Mahomes. He's good. He's good. He's got a dad bod. Yeah. So again, just think of us as your functional and quality of life quarterbacks. We're here for you. I think it's just incredibly important. Again, we got to get back to the things that we need to do, but also the things we want to do. So that is it for my part of the talk. Thank you all for listening.